Welcome and thank you for joining us today. For those that are new to RISE, we are the premier community for healthcare professionals, facilitating connections and providing insights through virtual and in-person conferences, online courses, certification, and timely content in webinars like this one. Thank you for joining us today.
Well, hello, everyone. Welcome to today's webinar. My name is Ray Gross, and I'm the Coding Education Manager at Centauri Health Solutions. So it is my pleasure to speak with you today. So just to tell you a little bit about myself, I have been in the healthcare industry since about 1999. Oddly enough, I have never worked on the clinical side. I've always been on the administrative side. Start off just doing simple signing of claim forms, progressed through, worked in medical billing for a period of time, owned and operated a medical billing company, but coding has always been my passion. And then in about 2015, I moved into the risk adjustment side of the arena of coding and really fell in love with it and have spent most of my time there. Currently, I am the education manager at Centauri. And so during the time that I've been working here, I pretty much work with the coders so that they're better able to understand the guidelines. I spend a lot of time diving into just industry standards. So the protocols, deep dive with, CMS and OIG. So that's pretty much where I am right now. So it is my pleasure to talk to you all about some of the different changes that we have coming on board with HHS RADV this year. So I'm going to be monitoring the chat as much as possible. I will try to answer as I'm going through. However, if I miss something, I will definitely answer it at the end. So sit back and relax and we will jump right on in. So throughout this presentation, we're going to cover several different items. First will be, why is risk adjustment so important? We're also going to talk about what has changed from the beginning since risk adjustment first became a thing to where we are now. We've had a lot of significant changes. We're also going to talk about the changes for the 2022 benefit year for the HHS RADV protocols, namely the lifelong permanent conditions list that has been removed. So we'll talk some time about that. How this affects the health plans as well as the providers moving forward. We'll also talk a little bit about how retrospective coding is going to be impacted. So we'll spend some time talking about those of you that are working on the backside of things. And then what should you do now? So why is risk adjusting so important? So the main purpose is to make sure that the patient's chronic conditions are assessed at least one time per year. So historically, we all know about those chronic conditions, your diabetes, especially your diabetes with complications. We also, talk about CHF and the different forms of CHF. We have AFib, and there's numerous different types of conditions. So I always think about you have that difference between what we term as the CMS 8 for Medicare projects. And then we also, when we think about HHS RADV, more about that commercial side, we think about that lifelong permanent conditions list. So the CMS 8 is something that we've, sort of coined. Isn't necessarily what I would call a defined condition by CMS, but we do know that we have those chronic conditions that the providers, should be assessing at least one time per year. So when we talk about, some terminology would be meet, some term that as tamper, or I think about support in general. So, what is support? So making sure that the provider talks about the status of that patient's chronic condition. So, something as simple as stable, unstable, uncontrolled, those types of things we want to see documentation of on the specific date of service on that specific encounter. You also want to look for things as how is that chronic condition being managed? So is there an order for labs for a condition? Is there some type of dietary change? When you think about dietary change, though, it's very common for providers to just say, watch your diet. But we're looking at those providers to really make that connection of what is actually being managed. So if a patient has, say, hyperlipidemia, for example, you're looking to see, are they doing something to control lipids? If the patient is a diabetic, are they mentioning some type of, diabetic diet? So those are the types of things we're looking for. So any type of management, are they ordering specific labs for something? So those things fall align with when we talk about support. And then follow up to conditions. So, think about, is there a follow up in 3 months? Are they referring out to cardiology for maybe their CHF or coronary artery disease? So when you think about follow up, I do want to mention that we also have to think about, we talk about the term chronic. So from a coding perspective, we know that there are certain conditions that risk adjust. But when we think about chronic conditions that are truly chronic in nature, when you have conditions defined by ICD-10 that are listed as what we say acute, maybe in the description, or when I think about acute, the difference between, from a coding perspective, DVT versus chronic DVT. So that DVT alone is considered acute by default. We need to make sure we're looking at really good support for those conditions. Even the cancers, so any of our neoplasms, those conditions are chronic by nature in terms of HEC value, but we need to make sure that those conditions have a little bit more than that term stable. Or when I see, breast cancer and I see the word stable, we really need to look at something a little more detailed for support. And we'll talk more about that in just a little bit here. So we're going to talk about some of the changes that go along with CMS and OIG and why we're where we are right now. So what has changed? So in terms of both the OIG and CMS, there have been some significant changes since the beginning of time. So we've come a long way. You think about COVID has really changed certain things in terms of, telehealth visits. There's been a lot of changes that have happened. But even before that, the OIG has really been looking carefully at documentation and realizing that there have been significant overpayments in certain chronic conditions that have not been properly managed. So the OIG has really pushed forward on going back and looking at records and extrapolating for conditions they felt were being overcharged and under documented is a term that I would use. CMS is also following suit. So CMS is to the point where they are now looking heavily at documentation. So what's interesting when you think about risk adjusting, especially on that retrospective side, you're thinking about documentation for the documentations for things that have happened in the past. So we're kind of catching up to these things. We're thinking about the history and so forth of CMS, and we're thinking about the history of risk adjusting in general. Risk adjusting has been around for a very long time. We're going back into Medicaid enacted back in 1997. We're looking at, Medicare jumped on the bandwagon really in 2000, but really has gone back historically since the 1980s. And a lot has changed in terms of where we are today. We've gone from paper records to EMRs. That has caused a lot of problems because EMRs are easy. They're great. They're more legible. For those of you that have been around for a while, you probably remember those handwritten records, that things were a little hard to read. So we have progressed into the EMRs. That has helped us, but in sometimes has hurt us, especially when it comes to documentation, and talk more about that in a bit. But from the commercial arena, we go back to the Patient Protection and Affordability Care Act of 2010, which was fully implemented back in 2014. So beginning with that 2017 benefit year, this is when HHS RADV began operating the risk adjusting program under Section 1343 of the Affordable Health Care Act. Okay, and that was covering all states, including the District of Columbia. So in terms of how things have changed, documentation must be key in terms of the way providers are able to get paid, including the health plans and so forth. It's really more important than ever before that there needs to be evidence of the providers being actively involved in the care of the patients. Okay, so we need to think about, did the provider truly assess these conditions, right? So we're going to talk more about that. We're going to break down the areas of the record in just a minute, so we can talk about some things that providers need to look for, and then just different things that, you know, will help all of us in general. So I do have a first polling question that I'd like to have you all answer. So polling question, what area are you associated with? I would just like to know my audience a little bit better. So I give you a few seconds to go ahead and do that for me. So what area are you with? It's really important, because I think as we work through all of this, we're going to find, depending on what area you're working in and what you're doing, you know, things will be a little bit different for you, or your perspective may be a little bit different. So I like to talk about all perspectives. Okay, so it looks like a large number of you, 63%, are with the health plans, and 20% are with the provider's office, and we have that 17% that are with the risk adjusting side, on the retrospective side. So that's really important, right? Because those of you that are in the provider's office, you have a perspective because you're in there with the providers, and you have that ability to query, go back. You're working hand in hand with those doctors, right? The health plans are seeing things from a different perspective, right? Because they're looking at everything as a whole. But then I want to talk about that, those of you that are on what I call the retrospective side. So those of you that are, you know, working for companies such as like Centauri, for example, where we don't have the ability to necessarily, we can't query, we have what's documented in front of us. And that's super key, because we only are able to code what we see, even though sometimes we know. And this goes back to that old rule of, if it's not documented, it didn't happen, right? So we see something, we know what we think what the provider maybe meant, but we're looking at what's documented in front of us. So keeping that understanding in mind, that would help us to better understand, you know, why the documentation on the front side is so important, so the providers are being reimbursed for what they should. And, you know, for myself personally, as I mentioned, I've never worked in the clinical side. I have a lot of background in, you know, medical terminology. I've taught in schools and taught medical billing and coding classes. But from my perspective, you know, I see things administratively, what's sitting in front of me. So we're going to talk about the different areas of the medical record. We're going to talk about that HPI and what's so important about the HPI, of course. We're going to talk about the past medical history, as well as those problem lists, which just most recently has really caused some major shifts and problems. We're going to talk about that and CMS's take on that. And then we're also going to talk about the assessment and plan and just other few key areas within the documentation. So let's talk about some changes for CMS for HHS RADV. So that's what most of this is going to be surrounding. So CMS has a cadence of calls, and a lot of these calls were started prior to the start of the 2022 benefit year. So there has been a lot surrounding the different types of lists. So I want to talk to you all a little bit about lists. So we have, of course, we term those as the PMH list, the problem list, and then any other type of list that you may see, maybe a diagnosis list. What's really important, and this was really mentioned heavily by CMS, is that we need to take caution in solely pulling from a list. Now, there is a difference between when you talk about utilizing the list and how that is utilized by the company you work for. So I want to make sure that there's that distinction. So there are conditions maybe that present themselves in a past medical history. Now, aside from talking about maybe how your specific company addresses that, just talking about those lists in general, when it comes to a PMH or a problem list, they're definitely an important area of the record, but sometimes those lists are, we'll go back to the EMR, they're pulled in. Sometimes they may be addressed by the provider, or maybe they weren't. But when it comes to any type of list, CMS has made it very clear that they want to make sure that the provider is assessing all of those conditions which are contained within any form of a list. Okay, and that's going to be include the medication list, which we'll talk about in a little bit, a little more detail. But those lists must be reviewed in some way by the provider. It can be something simple as reviewed. You just want to make sure that on that date of service, the provider has truly reviewed that medication list. So from a personal perspective, I have a provider that I see, all of my care is associated. I have a pre-visit, and I review my past medical history as a pre-visit. I say, yes, this is good. No, this is not good. So when you do that, the patient is I'm the one providing that information. Remember, we do not capture from patient reported conditions. We're coding things that the provider has validated, has substantiated. So we have to be careful looking at those lists. So CMS has stated that we're looking for evidence that that list was reviewed that day, meaning that the provider has addressed those chronic conditions within a list. Okay, that's any kind of a list. Sometimes you can look at the difference between when you're presented with a PMH list and a problem list. It's very evident that the problem list is a mile long and your PMH list can be a little bit shorter. So that that problem list sometimes is a hodgepodge of every condition the patient's had. You'll have headache, fever, everything that is historical. And then your PMH list, a lot of times, is a shorter list, which is more of those chronic, more current list. But even still, we need to make sure that the provider is assessing that. So that's where we get into that. Was the list reviewed by the provider on that day? It doesn't necessarily have to be dated in a sense, but you need to make sure that you're looking that it was reviewed. Okay. If you see a date that is in the past, you wouldn't consider that as reviewed on that date. Okay. So you want to see something that list was reviewed. In talking about other areas of the record, let's break the records down a little bit. So the HPI has a wealth of information. So within the HPI, sometimes the providers will make statements the patient has a history of diabetes and heart failure. Don't mistake that information as a history of meaning that it's in the past. That's, of course, as we know, how providers, document, which is perfectly acceptable. But we want, and sometimes there's a very direct statement. You may have heard the term active voice. So active voice is a very clear declaration that a patient has a condition. So the patient has diabetes. So what active voice does is it's a great tool for you because you know that the patient has that condition. The provider has told you the patient has diabetes. So that's eligible for what I'd call code capture, the E119. However, we need to go a step further. We still need to make sure that the provider is addressing that condition. So in other words, you're looking for, maybe in the HPI, the patient has diabetes on metformin. So the metformin is going to show that there is support for that condition. So I'm going to use the term support. I know some companies, again, use meat, some use tamper. So for simplicity, I'll use the term support. So the patient has diabetes on metformin. Okay, so diabetes on metformin, you know that the patient has the condition and there's active treatment for it. There could be something else elsewhere in the record, maybe in the assessment and plan, there's an order for an A1C. So in other words, when you have active voice, you still need to have support for that condition. So CMS was very heavily targeted on their calls that all conditions in the medical record must have support, right? So this is going back to, we've been talking, what we're going to get into in a little bit, the LOPC list. So all conditions must have support, okay? So active voice, again, is not enough. Sometimes we think about that as, okay, it's good, right? The patient has the condition, but think about what risk adjusting is. The provider needs to assess the condition, okay? Thinking about the assessment plan, another item that CMS called out specifically was conditions that present themselves in the assessment plan. Historically, I believe, a lot of times we've always seen a condition in the assessment, and we took that as it was assessed. And by right, that's sort of true. But as I mentioned earlier, when you have a handwritten chart, it's a little bit different because that's something that was written that day. Again, a lot of the EMRs pull information in. So information can be pulled from another area of the record. Some of you have probably seen where you have an assessment, and within that assessment, there's a list. There's a problem list added within that list, or a diagnosis list. We know that's pulled in. Okay, so we still need to take caution when things are cloned, or what we call copy and pasted. CMS is really all over that too. So what they specifically mentioned is, if you have in the assessment conditions 1, 2, 3, 4, the provider still must assess those conditions. So is it something where in the assessment it has CHF, continue Lasix? Does it have a separate assessment and plan where it's documented? Are you able to identify something within the HPI that supports those conditions within the assessment? Because we also have to be careful that in the assessment, there are many times where something is being ruled out. So, you go back to the HPI and it says the patient has had high blood sugars, questionable for diabetes, and for some reason diabetes is brought to the bottom of the record, but it's still really pre-diabetes. It has not had a formal diagnosis. Conditions in the assessment also, we need to be really cautious about conditions in the assessment, which I mentioned earlier. When you have cancer, so you have prostate cancer. Many times when a patient has had a form of cancer, it makes its way to the assessment. So you really want to make sure that those conditions that are in the assessment are current, meaning especially cancer. Are they on chemo, radiation? Prostate cancer is really big for watchful waiting, so they still have it. Some patients decline treatment, so they still have the cancer, but they don't want treatment or they've stopped treatment. So we want to look for terminology to support those, because although, again, they're chronic by nature, we don't want to give a patient a condition that they don't currently have. Okay, so acute conditions, is it a hospital follow-up where the patient had the provider documents MI, but when you read the entire documentation, that MI occurred 3 months ago, which would now make it an old MI. Okay, it's outside that 4-week window. So it's really important to, even in the assessment, scrutinize the assessment. Okay. Other things we want to think about is we've had this shift. COVID put us in a different situation. So we're seeing a lot of these telehealth visits now. So even when dealing with telehealth visits, one of course, the biggest things when it comes to any type of documentation for those dates of service, those encounters, is evidence of a valid face-to-face encounter. So sometimes we know with those telehealths, we may be missing areas of the record. We may not have what I would describe as a full PE necessarily. Okay, so the PE may not be present, but you see evidence of that interaction within the HPI, or many times in the assessment plan, you'll see that evidence. So all of these things we're talking about in terms of the PMH list and the problem list and the HPI, those are all irrelevant unless you first and foremost have evidence of that face-to-face encounter. Now, the next area that I want to talk about is going to be the medication list. So the medication list have been sort of a pain point for a couple of years now, I would say, in terms of IVA or HHS or RADV, and really across all areas. So whether that's Medicare, Medicaid, commercial, medication list is something that CMS is really cracking down on. So going back, one of the biggest changes with CMS this year, which has impacted the 2022 HHS RADV protocols, is again making sure that the providers are truly assessing these conditions. So as coders, we see a lot, whether you are, have never been in the clinical side like myself, or someone has been in the clinical side, we do know it's about that documentation. And because from our roles as coders, because we are not clinicians, we have to let the providers drive us. So what I mean by the providers driving us, in terms of using the medication list as support for a condition, the provider needs to make that linkage for us. We should not be using what we think in order to link a medication to a condition. So again, we should not, as coders, be using the medication list to link to a condition on our own. The providers need to make that link for us. Again, CMS was very clear about this. An example, you have asthma, J45909. You have albuterol, okay? We know that albuterol treats asthma, but sometimes albuterol can be given for something completely different. So without the provider letting us know that albuterol is for the asthma, we should not automatically be making that assumption. Another really good one I think about is diabetes, and we have metformin. Metformin can be used for other conditions. So in the absence of that provider clarifying for us that metformin is for that diabetes, we need to take caution. Okay. Other things to think about. You have patient has CHF and they have heart failure and they're on Lasix. So which is that Lasix being given for? Is it for the CHF or is it for the hypertension? So we really need to make sure that when medications are presented to you within a medication list, the provider needs to make that linkage. Now, you recall earlier I mentioned about the list needing to be reviewed, the PMH list and the problem list. That logic is still the same with your medication list. So those medication lists need to be reviewed on that date of service. I'm going to go back and use myself again. So when I schedule an appointment with my provider, I do a pre-visit. I'm asked, are these medications still current? Are these medications still current? Yes, no, taking, not taking. It's up to the provider during the visit to make sure that he or she is reviewing that medication list. Okay, because a patient can say, I'm taking it, I'm not taking it. Okay, so making sure that the list has been reviewed. Sometimes we even see those medication lists where it has patient taking, not taking, right? So all of us have different EMR formats, and then I'm going to give a little bit of additional information here. I, again, used to work in medical billing before my heavy days of doing nothing but coding now. I worked with different offices and did provider audits and was really exposed to different EMRs and how they're set up. So it was really interesting to see with my different clients how they were set up. And a lot of the EMRs are set up based on the way that, for Epic is a good one, but they're different formats depending on what clinic. So one of my providers, he actually set up the EMR himself. He was an MD, and it was really interesting because he let me sit down with him to see how he would click, and what would happen when he chose certain areas of the record. And the one thing that was really interesting to me was how he was able to really set things up in the system. So we cannot assume that because a medication list is present, it's actually been reviewed. So all EMRs are different. We have to remember that. But when it comes to the medication list, there's, again, two things that need to happen. Not only does the list need to be reviewed on the date of service, again, that simple statement of reviewed or some indication on the encounter that's been reviewed. So it doesn't have to be on the list. Don't forget about going back to that HPI. Provider may state in the HPI medications were reviewed. That is totally sufficient. But in addition to that medication list being reviewed, medications that are in there must be linked by the provider to use as support for a condition. Okay, so really key. So medications outside of the medication list, a little bit different. Many times, as in my previous example, patient's diabetic on metformin, you're good to go, right? So it's the list that really are stopping us. Really having to make sure that the providers are stating what medication is linked to what condition. It could be one medication treats multiple. So I mentioned the Lasix and the CHF and the hypertension, one medication. It could be just one. So that's kind of a mindset change. Again, CMS was very, very strict about this rule, I would say. They've really become a little more strict on it. And it goes back to risk adjusting was always about managing chronic conditions, but we've come a little away from that in a bit. And we're going to talk more about that in just a little bit here. So I'm going to stop here and take a look at the chat to see if there's anything that I need to answer. So a couple of questions that I see in here. So give me just a moment to pause. And if I don't answer you, I'm not ignoring you, and I will definitely get back to you. Um, let me see here. So what is my guidance on validating condition when dropped into the assessment? So CKD3 stable, labs are ordered, there's a GFR, and reported I-10, the code reported was in 1839, stage 3. So, and then you have a problem list, which has something that's a little bit different. So when I think about CKD, and I hope I'm answering the question that was asked. When I think about CKD, especially when it comes to pulling from a list versus pulling from an assessment, you know, many times, of course, we want to code to the highest level of specificity, but we also need to take caution in what is in the assessment and plan. CKD specifically, because things can change. A patient can go back or forth between, say, stage 3, stage 4, stage 5, and some of those vary on what's, you know, considered risk adjusting, what's, you know, a Hicks value, what's not. So I really think, honestly, when thinking about CKD and when thinking about the assessment plan, what did the provider assess that day? We really need to look at. Kind of another reason why I think, you know, CMS mentioned about not capturing solely from the assessment plan without support, right? Because things can change. You know, historically, if you have, like, for example, you know, CKD stage 3/stage 4, you go at the lower stage, you know. So really looking carefully at what's documented. You know, I'm kind of a broken record here, but going back to the HPI to see if the provider documented any possible changes. But for me, I think I'd probably default generally to what's in the assessment, but I'm one of these, and I like to actually look at documentation. Even with my own staff here, I don't like to answer general questions, but from a basic perspective of answering my thought process, that would be my thought process. Okay. So another question was, what are the requirements around attestations when the progress note does not have a signature? Can the health plan create an attestation for the provider to sign and validate documentation? Would that attestation be valid at the time of RADV? So speaking from the way that we do things, we have a flag that we apply when there is a invalid signature. So maybe it doesn't say electronically signed, by the whole authentication statement is missing. Maybe the creds are missing. So we do flag those and have the ability to go back and get that attestation. But that's how our company works. So it may be a little different for where you are, but yes, that should be acceptable. So next question. So for PMH and problem list, the provider must have addressed the conditions and know that these lists were reviewed on the date of service. Yes, that is correct. So as I mentioned, you know, being on calls with CMS leading up to the HHS RADV, that was something they were, you know, very critical about, because it goes back to, were those conditions actually assessed on the date of service? So they're looking for that assessment by the provider. So I think what's happened is we have shifted a little bit. We've been doing things a certain way and have kind of got away with it for a little bit. And now we're in a different stage, and we're going to talk more about that in a little bit when I get to the LLPC list, and I'll get some more details on that. Okay. So let's see. So all laboratory results that are used for the diagnosis or monitoring of disease can be used for support addition to the active voice, or they're only certain labs. So in terms of labs, I don't like to use, like, say, a CBC, right? A CBC is pretty much done routinely, I would say. It's not routine, don't misunderstand what I'm saying. But I would not take a CBC and connect it to every single condition the patient has. Now, if I saw a lipid or I saw an A1C, I would link those types of conditions back to diabetes or back to hyperlipidemia, for example. So it would be really the documentation would drive how that is. Now, if there's a CBC and the provider states they were doing it for, their hyperlipidemia would be acceptable, but I would not just take all labs to say that they're linked to conditions that need support for active boys. So hopefully that answered. Is there written guidance from CMS for support for all conditions? I don't disagree, but with this, just wondering if it's written somewhere we can use for education. So what was interesting is on the calls that we attended with CMS, and we're going to talk about how to get yourself involved in that a bit here. The meetings with CMS are recorded, but they're not shared. Some of this also goes back to those of you that have access to the coding clinic. So going back to the coding clinic, there's some guidance that they kind of latched onto that, we were told about outpatient conditions that they need to be reviewed. But really what it goes back to, the providers assessing those conditions within those lists. Okay, let's see here. I believe I answered this, but I'll answer again. So would it be sufficient for the provider to say, I review the problem list? Yes. So if there is a statement, it doesn't have to be on the list, but in the HPI, assessment and plan, somewhere in there, there is a mention that that list has been reviewed, that is perfectly acceptable. Yes. Okay. If a medication list has, for example, Lasix, and the doctor's order sheet states Lasix for CHF on order sheet, is that sufficient for capture? So as long as the provider is making a link to a medication to a condition, that is perfectly fine. We're not going to question anything that the provider tells us and what their logic is. We have to take caution sometimes, when we're trying to piece things together. But when it comes to the provider making that link for us, that is perfectly good. Okay. And I know I'm getting some questions about asking for links. I'm going to show you a couple of links in the presentation. I have a few on here, so hopefully these will help you out a little bit. Okay. Next, if the physician office doesn't report pre-diabetes and the hospital reports probable diabetes, since the inpatient outpatient rules differ, what does CMS do with inconsistency? So in terms of my response to that, it depends on how you're coding that chart. So if I'm on the outpatient side of things and I'm looking at an outpatient record and I don't have, and it's a follow-up, we'll just say follow-up, and it's after the fact, you're not going to be able to capture it, right? Now, if you're coding what I would deem as eligible for inpatient guidance, then yes, absolutely, you would be able to code that probable suspected. Now, I'm going to mention, though, when we talk about pre-diabetes, there's actually a specific code for pre-diabetes. So when you think about inpatient, if you have probable, suspected, ruled out, any of those unconfirmed diagnoses, and you're able to apply inpatient guidance, you can code as if those conditions are current, so probable CHF. But I think differently when there are actual codes or documentation for codes that are existent. So R739, if I'm not mistaken, I think is the code for pre-diabetes. So I'd be a little cautious in that. But when you don't have one of those specific codes, but definitely would not link together your outpatient follow-up visit to your hospital visit, if that makes sense. Hopefully that answered what you were thinking or asking. So what are my thoughts on diabetes status plan instead of meet or tamper? I'm leaning toward making this how I view whether or not a diagnosis can be captured. So, tamper and meet are very, very common phrases. They can be handled differently. So at our company and other places I've worked, we've adopted that term of support. And I think support, at the end of the day, CMS doesn't care what you use. They just want to see that the condition was substantiated, that it's eligible for capture, that there's valid support, right? So no matter what your approach is, and maybe, like I said, I'm using the term support, that's what it's about. Is there support for a condition? Do you have evidence that the provider truly assessed that condition? Okay, so I would look at it from that perspective. I can't, tell you what directive you should take, but I would definitely look at everything to determine whether that condition is substantiated. So, diagnosis, status, and plan. Plan would be, as long as something in the plan is documented, stating what the treatment is, I would take that to substantiate those conditions. The term diagnosis, you can code it or you can pull it if you have substantiation, but whatever terminology you choose to use, I just would say, just make sure you have support for that condition. Okay, I see some other questions, and but I want to kind of get through a few other things with you, because I know we're kind of getting down on time here. So don't think I ignored you if I'm pausing your question for a bit, but I just want to make sure that we have time to get to some of the really important stuff. But thank you so much for your questions, love them. So let's get into these updates. So I'm going to skip through a couple of these really fast, but I do want to spend some time on the lifelong permanent conditions list and talked about why that change occurred. And then we're going to talk also about some of these state-specific credentials, and then just going to kind of do a brief touch over on the super HCCs for infants, okay? So most of you probably recall back in the 2021 benefit year, we had a change to the lifelong permanent conditions list. On my screen, you can see there was a listing of some of those HCCs that were added. There were some that were removed, not full list, but those listings. And CMS was kind of like, okay, these conditions are present. We know that they don't go away, so you can capture. You don't even need to have support for them. Now they've done a 180. We've shifted. This list has now been removed for the 2022 benefit year. Now, what's interesting, as you know, we're sitting in 2023. So these are things that occurred. This change was something we're doing retrospectively. And I know there was a lot of upheaval. Remember what I've said a few times now. Providers have always been required to manage a patient's chronic condition. So CMS's logic on this whole shift and turn was that we've given you all this leeway in the past to say you can capture without support, but really these conditions should have always been treated, okay? So that's why we're where we are today, is that they're saying, we're asking you to do what you should have always done, even though we told you didn't need to do this, if that makes sense. So now we're going to have to dig and scrape a little bit. Okay, so I have my next poll question coming up. Just curious to where you are, especially if this whole CMS reduction of the LLPC caught you off guard. So we have this next poll question, if you all could take some time to answer. Not a right or wrong answer. So some of you may have been caught off guard and surprised. Some of you, there may not have been so much of an issue. And for some of you, maybe it's a slight concern. So interested to see your answers on this, if it affects you. I think it was a shift. I think it was a shock to our company, but not so much. We work retrospectively, so kind of a little bit of a changing point here, because as we're looking at things, so let's see, 20% of you said it is not a concern, okay, because you just want a concern. 73%, that's staggering, mentioned that it was a slight concern, which is not a problem. We'll talk about why in a minute. And then some were very concerned because they weren't managed at all. And that's okay. So that doesn't mean that all of a sudden, oh my goodness, what you can't do anything about the past, but we're talking about these things so you can move forward, right? So for those of you, the good news is when you submit over your chases, if you're using a company like ours, there's more than one date of service available. Hopefully we can validate it on one of those dates of service. Remember, one time per year, we're looking for that one time. So we may not have received it on this time, but we'll get it another time. Okay. So interesting. So, we just need to make sure that going forward, you're working hard to make sure that those conditions are substantiated. We're going to talk about that in just a second. We're getting low on time here. Two things I wanted to mention that I think as a result of previous items was state-specific credentials. We started seeing this a lot last year where providers, we would see credentials on an encounter that they weren't those traditional, like MD, DO, PT, things like that. So CMS made it very clear this year that we should be recognizing state-specific credentials. So if you have credentials that are specific to your state, make a list of those. If you have companies that are doing your validation for you, your IVA for you, it may be, good practice to go ahead and have those together so that if there's a question that a credential is valid for your state, there are no issues, because, what's valid in California may not be valid in, say, Wyoming, for example. So, and then CMS defines that as a provider that is a licensed physician or qualified healthcare practitioner who is legally accountable for establishing the patient's diagnosis in a state. And all of this can be found in the protocols, and I'll show you how to get to that in just a bit. To make note also, anesthesiology and echocardiography and therapeutic radiology, those have been removed from risk adjusting availability. So we know echoes were removed last year. The one thing that's a little bit different is you are able to capture from pre and post anesthesiology. We're talking about those anesthesiology records. And there's actually a really great example in the 2022 protocols that gives you that example if you're uncertain as far as how to proceed with that. Okay. And then I'm not going to spend a lot of time on this because there's a couple of things I do want to get to, but in the protocols, and I'll show you how to get to them if you have not seen them. But for those of you who have, just make note of the super HCCs for infants. There's been a little bit of a change in that approach. So just want to make sure I call that out to you all today. So what is this effect going to have on the health plans as well as those providers? So because of the reduction or the removal of the LLPC list, there could be the health plan seeing a reduction of the amount of validated HCCs, especially if there were conditions on there that were never really truly assessed, and your retrospective validation department is not able to see that a condition was validated. You might see that reduction. So going forward, you really need to work on making sure that those conditions are assessed now. The provider's office may see that slight reduction as well from that perspective in the reimbursement for that patient's chronic conditions. So what you can do now is start that documentation process now. Don't wait. Just go ahead and start doing it now. You can't go back in the past, but you can do that today going forward. Work with your documentation improvement specialists as well as your coders. You all need to be on the same page to make sure that, CDIs, talk to your providers, let them know about these changes, let them know that it's really crucial and critical that they're doing everything that they can to document well, okay? And then, CDIs and coders work together. Providers work with your coders, okay? We all want to make sure we're all on the same page, but the one thing that I always say about anything is communication is key. And going back to what I mentioned, if it's not documented, it didn't happen. So we just need to see it on paper. That's all we need to do. But the documentation is going to drive that. You know, if I'm not sitting in the office and I can't query, I can only go according to what is sitting in front of me. So what is the impact going to be on the retrospective side, what I just talked about? So the advantages is that anyone that's working in HHS RADV should be well versed in the 2022 protocols. If they're not, I'm going to show you in a moment how to get to that, how to sign up for them, how to make sure you have the most current information. The good news is the protocols does require that everyone working on HHS RADV is a certified coder, and a minimum of 5 years for the auditors. So that's good. The one thing I do want to mention just really quick is we talk about certified coders in terms of, say, for APC. APC has now made the CRC a core credential most recently in the past few years or so. So keeping in mind that some of the coders, they may have been a CRC for several years, but have never put their hands on a CPT or I-10 book. So just keep those things in mind. And that's why it's really important to understand that coders cannot use their clinical, providers. We're looking to you to make sure that you're documenting for us so we know what you intended to do. The disadvantages on that retrospective side, many times, again, we cannot query, and we're only able to capture from what's actually documented. So really important key here. So what do you do now again? Join RegTap, and I'll show you how to get to there if you haven't seen that already. So join RegTap, that's where all of the HHS RADV information is located. Get to know your protocol. So the protocols is like 200 and something pages, but the last portion is where it gets into documentation requirements, those face-to-face encounters and all of that. So get to know your protocols. There are also periodic updates throughout the RADV season. So make sure by joining RegTap, you have access to those updates. Start improving that documentation right away. I just said that several times, and making sure that those chronic conditions are assessed at least one time per year. Just takes that one time. You may have 15 visits, but you want that one clear encounter which has that validation of that specific chronic condition. So here are some references that you have. So RegTap, you want to join that, free to sign up. So get on RegTap if you're not already. I also put the link on RegTap once you're signed up as far as how to get to the protocols for this year. And they also have the previous protocols, so if you want to do that comparison for some reason, and then just some information about HHS RADV in general. So that is the end. I was trying to get that last bit of time in. I really appreciate all of you. I know there was tons of questions that have come in, and I will see if there's a way for me to get answers to you on those. I wish all of you the best of luck as we move through this 2022 benefit year. Hopefully this was helpful to you, and it's been my pleasure actually spending the past hour with you. So thank you, everyone.